Thanks, Christina. So it's my privilege to introduce our speaker for tonight, Dr. Megan Collins. She's the Alan and Claire Jensen Professor of Ophthalmology, and she's a pediatric ophthalmologist who provides comprehensive clinical and surgical care to pediatric patients and adults with strabismus. Dr. Collins completed her medical degree, ophthalmology residency, and fellowship in medical ethics at the University of Chicago. She then completed a fellowship in pediatric ophthalmology and adult strabismus at the University of Toronto. She received a master's in public health from the Johns Hopkins University Bloomberg School of Public Health. Currently, Dr. Collins is an associate faculty member at the Johns Hopkins Berman Institute of Bioethics and is course director for the Wilmer Residency Ethics and Professionalism curriculum. In addition to her clinical and teaching roles, Dr. Collins leads Johns Hopkins involvements in Vision for Baltimore, which is a collaborative school-based vision program providing vision screenings, eye exams, and eyeglasses to children attending Baltimore City Public Schools. So thank you so much for being here, Dr. Collins, and I'll turn the floor over to you.
Thank you so much, Jimmy, for the introduction. Nice to meet the whole core team of the Hopkins Virtual Ophthalmology curriculum, and thanks to everybody who's joined today. As you can hear, I'm getting over being sick, so I apologize if my voice is a little bit raspy. I'm going to start by giving you a little bit of background about pediatric ophthalmology, a little bit about my work, and then we'll transition into question and answer time. I'm supposed to talk about my pathway to pediatric ophthalmology, which I will, but I'm actually going to give my presentation first because I think it sort of tells a story in and of itself. I am more than happy for you to interject with questions. Once I start sharing my screen, I won't be able to see your questions. So maybe if somebody on the leadership team here can monitor the chat, or if you raise your hand, either are fine with me. Let's go ahead and share my screen. I should also say congratulations to all of those of you who have submitted your applications for this year. It's a big deal and an exciting process. Okay. Gonna drink some tea and go ahead. A couple disclosures that I like to share at the beginning of the presentation. And today, we're going to talk about 4 different things. Primarily, we're going to start by talking about some common pediatric eye conditions. I'm going to talk to you about some of my work, which is focused on health disparities in pediatric eye care, which will lead into models of school-based vision programs. And we'll end with why I decided to choose pediatric ophthalmology for my career and some question and answer time. So when we think about, and I'm going to invite you all to put some ideas in the chat. When you think about eye problems that kids have, what type of things come to mind? I see at least somebody has. Great. You guys are smart. I don't even need to give the presentation. So perfect. So you've already kind of hit number 1, number 2, and number 3 with kids. Very different than when we think about adults with eye problems. You would probably say diabetic retinopathy and cataracts and glaucoma and macular degeneration. All of those are serious eye problems that typically do not affect the pediatric population in high numbers. But the main things that we think about in kids that you see the most often, that I see every single day in my clinical practice, are uncorrected refractive error, strabismus, and amblyopia. So we're not going to spend too much time on any of these conditions, but just to give a primer that I think will help as we go through the next part of the presentation. Strabismus is really misalignment of the eyes. It can be horizontal, as you see in these pictures here, with the eyes turning in esotropia or out in exotropia. It can be vertical. It can also be torsional. The eye can actually extort outwards towards your ear, tort inwards towards your nose. This can be congenital. Somebody can be born with it. It can also be acquired either in childhood or in adulthood. And the treatment options are going to run the gamut from observation, if it's mild and mostly asymptomatic to surgical interventions, glasses, patches, or sometimes, honestly, most of the time, a combination thereof. Okay, so refractive error. Refractive error is the most common condition that you will see in kids. And these terms, I'm sure, have probably become familiar to all of you interested in ophthalmology. So there's hyperopia, commonly referred to as farsightedness, myopia, commonly referred to as nearsightedness, astigmatism. You've probably heard an ophthalmologist give the example of kind of your eye being more the shape of a football than a basketball. Anisometropia you might be less familiar with. That is when there's actually a difference in the refractive error between the two eyes. Say one eye is myopic and one eye is hyperopic, or one eye is a little bit myopic and one eye is really myopic. The important thing is that most kids who have some type of refractive error requiring glasses don't even know it. They're often asymptomatic, and that's just because sort of how they grew up, right? They're born and their vision is what it is, and they don't have anything to compare it to. So it's really important to recognize it's typically an asymptomatic condition, which is where vision screenings become really important as a way to detect kids who might be at risk for uncorrected refractive error. Amblyopia is the leading cause of vision impairment in children, and amblyopia is really sort of a neurodevelopmental disorder in that it's not necessarily that there's something anatomically or structurally wrong with the eye per se. It's that there may be another condition, whether it's strabismus, high amount of refractive error, or a cataract or a droopy eyelid, but something is impairing visual information getting to the brain. And so over time, and particularly when this happens early in life, the brain starts to favor the visual pathway of the eye that it can see clearly out of versus the eye that it can't see clearly out of. And a cataract is always a good example. So if you have cataract in one eye and you have a clear optical axis in the other eye, the brain's going to favor the eye with the clear access. And if you don't correct whatever problem is driving the amblyopia early in life, turns out you can have permanent vision impairment. So if you have a congenital cataract that you don't correct till the age of 10, even once that cataract is gone, that child will still have a hard time seeing. And treatment options for amblyopia, we always start with glasses when they're needed, but the most common are actually some type of penalization therapy, which means that you're either patching or atropenizing the stronger eye to force the child to use the weaker eye. Dichoptic therapy, which is these kind of virtual reality headsets, have become more popular in the past couple years. And there's one out there that you can Google. It's kind of interesting to look at luminopia. And as I alluded to, treatment's most effective when kids are younger. Uh, that being said, if I have kind of a treatment naive 14-year-old that's never been patched before, I would start patching them, but I'm most likely going to have the most robust effects when kids are younger. Okay, so as we've gone from kind of the big picture of here are some of the most common conditions we see in children, I'm going to transition very unelegantly into talking about healthcare disparities. So recognize that there are many drivers of disparities in healthcare, both in terms of access and outcomes. And this is something that's become, a big focus of the American Academy of Ophthalmology within the past couple years. And I think 2-3 years ago, they actually convened this task force on disparities in eye care. And I always like this quote because I think it's so important to recognize that if we really want to talk about addressing disparities, we really have to be sort of multilateral in our approach in improving access to care, increasing diversity in our workforce, enhancing eye care and healthcare literacy, and leveraging data. So that's sort of a good transition into thinking about disparities in pediatric eye care. There's a preponderance of data that your race, your ethnicity, your socioeconomic status, your zip code, so many things can be actually drivers of not only your prevalence of refractive error or other types of eye conditions, but also your outcomes. And this was driven home recently by an article by another member of our pediatric division at the Wilmer Eye Institute, Michael Repka, looking at a database some of you may be aware of now called the IRIS Registry. It's a big American Academy of Ophthalmology database of its claims data, basically. But what they found is, now I've just talked to you a little bit about amblyopia and the fact that we can treat and we can treat effectively. But interestingly here, amblyopia treatment outcomes were significantly poorer for Black children and those with Medicaid coverage, just showing that even things that we have exceptional treatment for, you have disparities driven by race, by insurance coverage, and other factors. So let's kind of think about that from the lens of how do we find out when kids have vision problems in the first place? And by and large, in the United States, one of the most common ways that we detect when kids have vision problems is through vision screenings. And vision screenings are typically mandated by states, and they're mandated often in the preschool population and the school age population. This slide actually exemplifies what the vision screening requirements are by the state in the school age population. And as you can see, there's a lot of green. So most states do mandate vision screening at some interval in the school age population. Although any of you who might be from some of these states in gray, those were states that when we published this now a couple years ago, we're not mandating vision screening. And any of you who might be from the states in blue, your states are the high flyers here. These are the ones that are mandating vision screening in annually or every other year. In addition to this, just to add a little bit of complexity, because in case some of you are interested in advocacy, this is really an area that there are position statements by the American Academy of Ophthalmology, the American Academy of Pediatrics, the American Association for Pediatric Ophthalmology and Strabismus about vision screening. And then there are state mandates. And the interesting thing is they don't always they're not always equal. So what the academy might say in their position statement might be different than what a state says. And interestingly, all of this might be very different in terms of what happens at a state level, in terms of what insurance companies will cover, particularly state insurance plans. So after a vision screening is really where we see even more marked disparities. So we see that there are these mandates for kids to get vision screenings, but what happens afterwards? So a vision screening, I should say, is simply a cursory assessment, typically done in the community setting, might be by volunteers. I know some of you probably as medical students have been involved in screenings. School nurses do these. Sometimes health department has vision screening teams. Pediatric nurses will do this in the primary care setting. But what typically happens after a screening is kids and parents get a form that says, you've had an abnormal screening, you need to go find an eye doctor. And that's often where the challenge lies. There's a lot of data that depending on where you live, depending on your insurance, it's much harder to get access to an eye doctor, whether it's an optometrist or an ophthalmologist. So there's this significant drop off between having an abnormal vision screening result and having access to an eye exam. There's even drop off after having an eye exam because sometimes insurance plans will not cover eyeglasses. They won't cover replacement glasses. So our data suggests that if you're coming from a high needs community, if you're coming from a racial or an ethnic minoritized community, you actually have less access to screenings, less access to eye exams, less access to glasses, and less access to replacement glasses. And all of this within the pediatric population, culminates in sort of a large unmet need for pediatric eye care, particularly in the school age population. I mentioned the American Academy of Ophthalmology task force on task force on disparities in eye care. One of the things that really heartened me was that in terms of their recommendations to improve access, they started talking about schools, and they talked about school-based health centers, school-based vision programs, and vision screenings. And this, of course, is where my work has been focused for the past decade. But I was so happy to see that attention thinking about the idea of where do schools fit in access to healthcare for kids. And this becomes really important. And I won't ask for a show of hands because I can't see your hands right now. But, probably as medical students, you've spent little to no time in an elementary, a middle, or a high school setting. Um, nor did I when I was a medical student or a resident or a fellow. But it turns out that there's really robust data about the intersectionality between health and education. So students who aren't healthy are less likely to come to school. Students who are high achieving learners end up having better health literacy and better health as adults. So it's really interesting to sort of see this schools as this nexus of where children are educated, but also where they can access some of the preventive health services that are important. And that can be things like vaccinations, it can be dental care, it can be mental health care, it can be other preventative services. So what about eye care? That was really the question that we asked is, can we deliver eye care in schools? We see these marked disparities in terms of outcomes for kids from more disadvantaged backgrounds. Could we bring their eye care to school? And the answer is yes, we can. Um, and this becomes even more relevant for kids because the image on the left side of your screen is intentionally blurry to illustrate for you what it might be like, say, if you were nearsighted and sitting at the back of the classroom. That might be your experience of what looking at the board is like. And there's been a lot of interest in the pediatric optometric and ophthalmology community over the past 5 to 10 years as to actually measuring the impact of not having glasses on school performance and also of having glasses. Does that help make you perform better in school? This has all been compounded by the pandemic. Any of you who've kind of followed the education news have probably seen a lot about achievement gaps that have widened during the pandemic, largely driven by we see huge racial, ethnic, and socioeconomic disparities in terms of performance on standardized math and reading assessments. We've seen huge issues with chronic absenteeism and kids not coming to school. So think about how powerful it could be for a child who is struggling in school, can't see, isn't accessing healthcare in the community, what a game changer a pair of glasses could be for them. And that was really the impetus behind establishing what's known as Vision for Baltimore, which is our Baltimore City, which is its own county in the state of Maryland. So this is a district-wide school-based vision program that is kind of co-organized and managed by all of the entities listed on this slide, including our local health department and school system and Johns Hopkins University and health system. And then we have a couple of national partners, including Vision to Learn. They're a mobile optometric nonprofit that actually brings optometrists into the schools to perform the eye exams. And then Warby Parker that actually provides all of the glasses. They donate all the glasses for the program. And one of the unique things about this program, and this is a happy kid who got a pair of glasses through the program at one of our events a couple years ago, is we recognize that in order to overcome this access gap, all care has to be delivered in school. And it can't sort of be, we'll just do screenings at school or we'll just do exams at school. It has to be, we do the screenings first at school. We send information home about how to have the eye exam at school. We get permission from parents. We do the eye exams on site at school. We send information home to parents about the eye exams and the outcomes. And kids are able to pick out the glasses they want themselves, which is a big deal with kids. They want to pick their own size, color, frame. All of those types of things are important to them to get excited to wear the glasses. And those glasses are then ordered and then brought back to the school and fit on the students at schools because if your glasses are too big or too small, you're less likely to wear them. So we've recognized all of those are really important to making sure kids have access to eye care. But we also recognize that we have to go beyond that too. There's got to be a lot of engagement and trust building in the community. And I suspect any of you who might be involved in volunteer programs or vision screening programs recognize how important this piece is, that it's not sort of episodic care. It's an ongoing institutionalized relationship where we go to back to school nights, we talk to teachers, we talk to parents, we try to make sure everybody understands the purpose of this program, the significance of not having not having an eye problem addressed if you have an eye problem, and the resources that the program provides in terms of access to eye exams and glasses. And I should say the program is supported through grants and philanthropy, so there's no out-of-pocket cost to people, because one of the questions that often comes up from community members is sort of, how much does this cost? What's my eligibility criteria? And we felt it was really important for our program to have, no eligibility restrictions and no cost restrictions that would preclude somebody from participating. And the program, as you can see, has been, honestly, I think, one of the most successful school-based vision programs nationally. We now have reached 20,000+ eye exams, given over 15,000 pairs of eyeglasses to kids in need over the past 9 years. My slides are advancing themselves. There's probably, my slides are pushing me along. Anyway, sorry about that. I'm going to go through a little bit of the research data because, and this is, I think, a really important point to think about when you are building community initiatives. One of the important things is obviously developing partnerships, positive partnerships, engaging with your community. It's also important to think about collecting data so you understand what you're doing well, what you might not be doing well, what your outcomes can be so that you can replicate it. So it's important to think about not just, we just did something in Baltimore, great, but how do we use the lessons from what we did in Baltimore to make our program stronger in Baltimore? And how do we use the lessons learned from what we did in Baltimore to help another school district, to help Detroit, to help New Haven, Connecticut, to help other places that are struggling with the same problem? Because I will tell you, and I'll do a shout out to Christina here quickly. We've recognized that many school districts across the U.S. are the virtual identical problem we have in Baltimore, and have come to us to help understand, what did you do to fix it, and how can we implement something similar in our community? So a lot of our work has really been around disseminating these findings and disseminating best practices, so not everybody is reinventing the wheel. So one of the things that we asked early on was how many students were actually failing a vision screening, because as you can imagine, stakeholders are interested in this number. Is it high? Is it low? If it's really low, then they're going to say, well, why do you even need a program? If it's really high, they're going to probably pay more attention. And what we found in Baltimore was it was really high. Our screening failure rate was about 34% on average across all grades. In this slide here, I'll distinguish the blue from the yellow here. The blue are the grades that are mandated by the state of Maryland for kids to have vision screenings in, and the yellow are the grades that we actually added as part of our program. And we published this analysis a couple years ago in JPOST. First, showing this is high failure rate. So if 1 in 3 kids in every single grade is failing a vision screening, you have a serious unmet need and an opportunity to build some type of mechanism to address it. The other thing is it's consistently high. It's not like it's just high in the first few grades and then it goes down. If anything, it trends upwards. And we think it trends upwards for 2 reasons. One, as kids get older, we tend to see more myopia or nearsightedness. So that's one of the reasons. But the other is clearly the system that we have in place before we built our Vision for Baltimore program is not working. Because if it were, you'd have a vision screening in kindergarten or first grade, you'd get glasses, you'd be plugged into the system so that the next time you had a vision screening, you wouldn't fail. And the fact that we see such a high number failing as the grades go on is actually data that we've used to work with the state about thinking about expanding the mandated grades in the state of Maryland, with the conversation now being had about, should we add grades 3 and 5? Because that's sort of where the big gap is. Now, the next thing that I'm going to talk about, I know at the beginning we talked a little bit about strabismus and amblyopia. Here today, I'm going to present just what our refractive error findings are for the program. And this slide's a little bit noisy, but let me walk you through it. So, at the x-axis, we have all of the grades. And then we have this distribution of refractive error that was seen, whether it was myopia, hyperopia, astigmatism, or anisometropia. And what you see is pretty classic trends. Myopia increases, and again, that may be a reason that we saw some higher vision screenings in the older grades. Hyperopia decreases. Astigmatism astigmatism is sort of decreases a little bit and stays pretty stable. And anisometropia, which again is that refractive difference between the two eyes, stays pretty stable. That's not surprising. Those are all things that we know from, larger population-based prevalence studies in kids. If anybody's curious about sort of our non-refractive problems, the amount is pretty small. I think, from this data set, maybe it was less than 8% of the population had something that might be greater than refractive error, meaning being an amblyopia suspect, having strabismus, having something else on exam that required further evaluation. So then the next question becomes, from a research perspective, okay, well, you gave them glasses, can they actually see better? The hope is yes, obviously. And what we saw was actually a pretty robust improvement in vision for kids through the program. And this slide is organized into their better eye and their worse eye. Better eye meaning the eye that maybe one eye saw 20/40 and one eye saw 2100. 20/40 would be their better eye. And this is broken down by lines of improvement, anywhere from one line on your standard Snellen eye chart to greater than 5 lines. And as you can see, again, pretty robust improvement in vision in both the better and the worse eye. And I think what our data has shown is maybe over 90% of kids are getting to 20/30 or better visual acuity with glasses through the program. And that shows to me two things. One, it shows you have a high amount of uncorrected refractive error that you're improving. Two, you don't have a lot of untreated amblyopia, because if you had a lot of kids who had amblyopia, they probably would not improve with simply, the pair of glasses alone, particularly in this age range. So that's a good thing to me, that we actually are seeing, so many kids that can simply improve just with the glasses. So our education colleagues, our policy colleagues, all really interested in the question of how much of a difference does this make for learning. And one of the cool things about this project that I've loved was actually the opportunity to work with researchers in education from our Hopkins School of Education to measure the impact on learning. And this is a study that we published a couple years ago in JAMA Ophthalmology, actually reporting for the first time in a large randomized controlled trial in the US, looking at the positive impact. Interesting thing, we see a positive impact on reading, which is measured in terms of test scores for English language arts, not on math as much. We saw larger gains for girls, students in special education, and students who are in the lowest quartile of their class at baseline. And our education colleagues helped with some fairly sophisticated analysis to model out, particularly for our education and policy stakeholders, how would we equate this? What's the impact of getting a pair of glasses in terms of learning gains? And it turns out for all students who needed glasses, it's actually about 2 to 4 months of learning time. And for those in the lowest quartile, about 4 to 6 months of learning time, which, when you think about it, almost half a year of learning time is the equivalent gain to getting a pair of glasses that you need. I mean, that to me is really groundbreaking news. So very briefly, when we think about vision for Baltimore in total, we've uncovered a huge unmet need in our local community in terms of kids having a problem that wasn't being recognized effectively and wasn't being connected to care. And we developed a system on site at schools that was able to provide access to that care. Importantly, we now have measurable outcomes of improvement, both in vision and in learning. So it's important that we think about this in terms of its opportunity to not only sort of advance health equity, but also to advance educational equity as we think about other school districts across the US. I've got my email up there. I am happy to answer questions about the presentation or anything else. I think I'm almost on time, Christina. Um, Now, I did put some slides in about costs if you want to see them. Because some people ask about this, which is actually the breakdown of how much it is for a pair of glasses and an eye exam. And it's about $105 per student when we did this cost analysis. Okay, I'm going to stop sharing my screen for a second. So, why did I choose pediatric ophthalmology? Um, I had honestly no interest in pediatrics as a medical student. I hated my pediatrics rotation, like full on, just couldn't stand it. Liked it more than psychiatry and OB-GYN, but generally, uh, I found it, I'm not sure. I found the dynamic hard uh, with with some really sick kids, and I thought, oh, I don't think I want to do pediatrics. My first rotation when I was an ophthalmology resident was pediatrics. I was terrified. I'm like, oh boy, it's not going to go so well. Um, and it turns out that I'm the youngest. I've never babysat much in my life. Like I haven't like been around a lot of people younger than me when I was a kid. So, but it turns out my personality actually fits really well with children. Small children and I tend to get along really well. So, like from my first day onwards, I just liked working with kids. I found them fun and engaging and challenging in ways that were really kind of inspiring for me to think about how do I figure out how to win over this kid? I also liked at the same time that I had to figure out how do I win over this parent or this grandparent or this guardian and get them on the same page as me. Because you'll see, I remember the first time I had like a mom, like really, like truly deeply crying when I said her child needed a pair of glasses. And I did not, for the life of me, understand at that point in time how somebody could be that upset about a pair of glasses. And it turns out, when we talked a little bit longer, um, mom had had like multiple miscarriages, had gone through IVF and sort of felt it was her fault. This was sort of this child had been born and I think had problems. And this was sort of like the tipping point of this kid's had so many different problems. And now on top of everything else, they have to wear glasses. And and it was really important that I actually got to understand that because I could have just dismissed it and been like, this is no big deal. Um, but it was a big deal to her. And I like that. I like that I need to, that's part of my job is to understand that and to really build those partnerships with parents and with kids and work together. At the same time, I also see a lot of adult strabismus patients, um, which I love because they're complex in a very different way. They also tend to read a lot, and I'm a very avid reader, so we often exchange book recommendations, which sounds silly, but super fun. Um, and, public health was not an initial part of my career, but ethics always has been. And ethics and thinking about the doctor-patient relationship and thinking about health equity and structural justice have always been sort of really kind of important underpinnings, I think, of the values that brought me into medicine. And when I sort of discovered the world of public health and thinking about, well, how can I translate what I do one-on-one in my clinic and surgical setting to a population, to a school population, to a community population. I actually love the challenges and opportunities there, and the fact that I'm able to serve an entire kind of cohort of kids that I wasn't seeing in my clinic, and that I can engage as an eye care provider with educators and school nurses and patient advocates in a very different I think platform than I'd ever been involved in before. And I have to say, I love it. I have a very cool job. I also have a crazy job at times, but I have a cool job and I get to do everything from, seeing babies in the NICU, to seeing kids and adults in my clinic doing surgery, and then doing a lot of work in community-based initiatives that not only can I kind of build those community programs, but also do the research side of it to help kind of build that knowledge and help others across the country and internationally. Now, I actually just joined the World Health Organization SPECS 2030 initiative. I'm on their scientific and technical advisory group, helping them figure out how do we think about sort of building infrastructure and systems globally to improve access to eye care. I'm going to stop talking because I have no voice anymore. And I'm going to turn it over to all of you to ask questions, and I will take a sip of my tea, and I'm here to answer them.
Thank you so much, Dr. Collins. So yes, if anybody has questions, feel free to type them in the chat, or ideally, if you can use the raise the hand function and then are able to say them live, that would be wonderful. All right, Benjamin, I think I see you first.
Hi, yeah. So my question would be, so for Megan's work in the WHO, how would you say that international problems compare to more domestic ones? Is there more issues that you would say that are unusual that we'd otherwise not see here?
I think actually the themes are the same everywhere. I think there are health literacy issues in terms of people being aware of having eye problems, and this is in pediatrics and adults. I think there are workforce issues in terms of shortages of optometrists, ophthalmologists. Sometimes there are hardware issues in terms of access to affordable glasses. So I think the needs are similar. A lot of the kind of universal challenges are similar. What might work in one community in Indonesia might be very different than what's going to work in Greenland versus what we do in the US. But I think that the kind of the issues at the heart of everything are very similar.
Emily, I see you next.
Hi, thanks, Dr. Collins, for sharing your perspectives and your research experience. I'm an M3 from Brown, and we've been trying to pilot some new school vision screening programs in the Providence public schools, and we came across very similar findings where roughly 30% of kids were receiving referrals to ophthalmologists. And so I was kind of curious to learn more about your experiences potentially regarding integration of devices into school screening programs. Sorry, since we're also partnered with the Lions Club and they've been using the Spot Vision Screener in schools.
Yeah, so yeah, Lions Club does actually use a lot of the Spot Vision Screener. So I think there are how do I put this? So this sort of the gold standard of vision screening in the school-age population is actually distance acuity. But there is a lot of in practice these days, a lot of people are using instrument-based screeners. And for those of you who don't know what instrument-based screeners are, maybe somebody from the organizing committee can like put a link to Spot Vision Screener or something in the chat. They often look like Polaroid cameras. And for those of you who don't know what a Polaroid camera is, you're too young for me to talk to. But they're a device that helps detect amblyopia risk factors. So typically it's looking at refractive error above or below a certain threshold, looking at misalignment of eyes. Maybe somebody has nystagmus and they can't fixate properly. Maybe they have a cataract or a droopy eyelid, so you can't see the visual access. And their tests that are done on a child, and it gives you kind of an output of pass fail. They have grown in popularity since COVID for simply infection control purposes, because you can imagine it's probably well, maybe you can't imagine, but you typically can be a couple feet away from the child with an instrument versus when you're testing their acuity, you maybe have your hand over their eye, and you're asking the child to repeat the letters, and sometimes it takes a while. So instrument-based screeners can be faster. And from an infection control point, arguably they might be less risk of transmitting things. That being said, most of the data historically on instrument-based screeners had been done in the preschool population. So it had been done in the pre-literate population, because you have kids who are 3 or 4 that we want to detect amblyopia or amblyopia risk factors, but they don't know their letters yet. So that's the group it had been designed by. So there has been sort of this philosophical divide as to whether they should be used in the instruments should be used in the school age population or not. I would say in practice, they are being used very often in the school population. I think that's great. I would love more data out there to report on it. We're actually doing a study about this right now. Christine is helping me with a paper on the guidelines about instrument-based screening in the school age population. So it's an area of a lot of interest. I'm not opposed to doing it. Again, it's not an eye exam. It simply detects somebody who needs an eye exam, and then you still have to build that whole system to get them for an eye exam. Thanks, Emily.
Thank you.
All right, Jay.
Hi there. My name is Jay. I'm a MS3 at the University of Miami. Thank you for your lecture today. It was great. As someone who is interested in pediatric ophthalmology as my eventual, career, I wanted to know a little bit more about how you balance, your pediatric population and your adult population. And you specifically mentioned how strabismus is complicated in adults. And if you could go in a little bit more detail on exactly why it's complicated.
So many reasons. So my clinical practice is probably 70% kids, 30% adults. My surgical practice is probably 50-50. And honestly, I think how much adult strabismus you do or don't do in your career is totally your choice, and where you choose to get a job and where you choose to practice. So University of Miami has Bascom Palmer, which of course is, one of the most well-known institutions in ophthalmology in the US, aside from Wilmer, of course, and also has a huge referral for adult strabismus. So you'll see a lot of adult strabismus if you're there. I'm at Wilmer. Wilmer is well known with some of the true kind of luminaries of adult strabismus, like Dave Guyton and Michael Repka, who've written the textbooks on it. So we get a ton of adult strabismus. Why is adult strabismus complex? Doesn't have to be, but I think I have a bias in terms of the referrals that we get here, which are very much regional, national, sometimes international, that people come here for their second, third, or fourth opinion. So strabismus in adults, it could be new in adulthood, or it could be recurrent / decompensated from childhood. And meaning that somebody may have had multiple prior surgeries in the past. They may be having issues with double vision. They may be having issues that are, impacting their ability to drive, their occupation. So it becomes complex because I think there's so many more sort of factors at play. Adults and their eyes are actually, kids' eyes are so easy. Like kids, most of them don't even need glasses, except as you can see, we talked about the ones that do. But adults are, if they're very precise in terms of their needs for refraction and prism and sort of adaptations to their glasses. So I think just as a population of patients, they have more complex needs. Sometimes you also have more medically complex issues. They have thyroid eye disease, they've had a tumor, they've had some type of AV malformation that's caused bleeding in the brain. They have other issues that are impacting their ability to fuse. So there are just sort of more factors at play. I don't know if I answered your question fully, Jay, but
No, you 100% did. Thank you very much. I appreciate it.
you should go hang out with your group at Miami.
Yeah, I'm hoping to reach out to Dr. Cavuto. I don't know if that name sounds
Eric
familiar.
Kavuta is lovely. Hilda Capo, you've got a great group there.
Exactly. Yeah, so I'm going to hopefully reach out to them and see
Wonderful.
what we're going to do with them.
All right, turn it over to you, David.
Hey, yeah, thanks so much, Dr. Collins, for your time. Sorry you're not feeling well. Quick
This is
question.
also, I should be full transparency, this is also the reality of when you work in pediatric ophthalmology, sometimes you get what the kids have. So
Yeah, very fair.
blame the children. Go ahead.
Very easy to do that too, right? So, other than kind of the general expectation that I have, coming in from like, increased screen time in the general public, not only with kids, is not necessarily a good thing for kids. As a pediatric ophthalmologist, is there anything that you've noticed and had more insight on with the increased amount of screen time, not only in the like public realm, but also in the classroom and almost every facet of life?
It's bad. That's the short answer. There are the challenge of so many things is it's sort of like policy versus practice, right? The American Academy of Pediatrics, everybody has guidelines about how much screen time you should have. And then there's the reality of how much of childhood is on screens these days because of school and education and social engagement, and you're zooming with grandma and grandpa, and you're playing all of your games and reading your books on devices. So it's a real challenge that we see with kids with screen time. And that's not even getting into like the whole issues of mental health and cell phones and social media and lots of other prolonged screen time with kids. I think the medical side is obviously we've seen an explosion of myopia globally. Particularly, there's a lot of data that came out during the pandemic that's suggestive of that there was an even sort of more rapid acceleration of myopia driven by the pandemic and people being indoors and spending more time on screens. And the other thing that we often see with kids is what's called digital eye strain. All of you may be experiencing it now that your eyes hurt after staring at the screen for an hour. And maybe even, I don't know, some of you may have done part of your medical school while on Zoom or undergraduate years, and you're just staring for hours and hours at professors and classes, and your eyes start hurting because you stare and you forget to blink, and your eyes get strained. So digital eye strain and myopia are sort of two of the very real consequences that we often see of prolonged screen time. There's some pretty robust data about physical activity and spending time outside actually reducing nearsightedness. And so I often tell families, actually, I think I always tell families to have their kids spend some time outside, and spend outside. And I always have to clarify, spend time outside without your devices, because they might just be sitting outside on their cell phone, which will help nothing. But I think I think it's important for their eyes, but it's important for their overall physical activity. It's important for weight management, everything else. So good question.
Gretchen, I see your wonderful question in the chat too. Are you able to say it live?
I am. Yes, thank you. I wasn't sure if my mic would be working, but thank you, Dr. Collins. I'm a fourth year from Buffalo applying this year, and I really appreciated hearing all you had to say today. I know you spoke a little bit about how your master's in public health has impacted your work, and it's very clear. And I'm curious if your degree in clinical medical ethics or your fellowship in the clinical medical ethics has impacted your work in ophthalmology and specifically in pediatric ophthalmology.
Thanks for asking. Yeah, definitely, very much so. I think one of the things that I wrote about early on was actually how do we think about informed consent and risk-benefit analysis of using anti-VEGF for retinopathy of prematurity. Because early in my career, that wasn't FDA approved to be used in neonates. There was not a lot of long-term data, and there was sort of a shift in practice, even more so within the retina community that treats retinopathy of prematurity than in the pediatric ophthalmology community. That a lot of people were using it, and we didn't have a lot of data about neurodevelopmental outcomes, and other things. And so I had written a paper when I was a fellow, actually thinking about how do we think about the informed consent process, and how do we effectively kind of engage, a very vulnerable population, parents of a neonate, to sort of assess the risk benefit calculus for their child. So always been very interested in informed consent and patient communication and the sort of the concept of the doctor-patient relationship. I think my work in public health has sort of broadened some of my ethics work into structural justice, health equity, kind of thinking about advocating for more equitable systems, and thinking about healthcare and eye health as a fundamental right. And at the same time thinking about how do we promote health literacy and sort of empower our more vulnerable populations to understand whatever medical issue might be at play, and how to help them navigate the healthcare system.
Thank you.
Grace?
Hi, Dr. Collins. Thank you so much for your talk today. I'm Grace, and I'm a second year at NYT Com, and I had a question about the vision screening failures. I was surprised to see that despite like all the vision screening and the glasses that you're able to give out, there was still a 1/3 of failure throughout elementary school. And I was wondering if your team was able to figure out or do a deeper dive into why that might be the case. I was wondering, is it people, are they new students who didn't have a problem that like are having problems, or are their eyes getting worse and they need new glasses every year? Or
Yeah, no, it's a good question. I probably should have elaborated on that data a little bit more. So our program started as a pilot that was serving all 150 schools in Baltimore over a 3-year period. So that data actually presents the initial vision screening failure at schools when we hadn't been there before. So that's not longitudinal data. That's actually just cross-sectional. The first time we went into any school, the failure rate was 30%. Failure rate's actually gone down since we've started the program. But when you do see, failures in grades, maybe they didn't fail in 1st grade and they fail in 8th grade, I think it's largely driven by myopia. Does that help answer, Grace?
Yes, thank you.
Excellent.
All right. Any other questions?
Can I ask a question?
Please.
I have a captive audience here. How do we get more people interested in pediatric ophthalmology? Because I will say, I've worked with so many exceptional medical students over the years, and I'm always sad when those exceptional medical students go on to ophthalmology residency. I think convinced about pediatric ophthalmology, and then 2 years later I get the call. They're like, well, things are going well, but I'm thinking about glaucoma. I'm thinking about plastics. So from your perspective as medical students, what do you see as some of the barriers to people pursuing pediatric ophthalmology, or what things do you think that we could be doing better as a profession? So I don't get that call 2 years from now.
I can just speak from my personal experience. I think for me, the reason why I became interested in pediatric ophthalmology was that on my pediatric rotation itself, I had like 5 patients with like IAH, and it was just really interesting to see the overlap between ophthalmology and pediatrics. And to be fair, I did have an interest in pediatrics already, and I just enjoyed my pediatrics rotation. So that's my background. Just more interested in ophthalmology, so that's why I'm doing that way.
Awesome. Thanks, Jay.
Naomi?
Can you hear me now? Okay. Hi, I'm Naomi and I'm M1. I'm also a first generation exposure. You hear a lot about, in general ophthalmology, maybe more so from your parents, things like that. So I think a lot of people going into medical school might not even see pediatric ophthalmology as like a field that they could get into. So that might be one of those barriers.
Very, very true. Yeah, I agree. Thank you for that. Which is why I love this curriculum, actually, because I think it's such a cool thing that we did not have when I was a medical student. I was going to say we didn't have the internet when I was a medical student, but we did. But yeah, I love sort of the accessibility this provides for and peer-to-peer support. I'm sure you guys will, some of you who are applying right now, I'm sure you'll run into each other in your Zoom rooms on your interview trail and have that support network, which is awesome.
All right. So with that, we just want to thank Dr. Collins for her time. And we also want to thank everyone for joining this meeting. And just a quick plug, please check our website for recordings of previous meetings. I just pasted the link in the chat. And also, please follow us on Instagram at Hopkins Ophthalmology VC. Keep an eye out for our monthly future sessions and posts. Thank you again to Dr. Collins.
Thank you all for this opportunity.